Microphone test, 1, 2. Microphone test, 1, 2, 1, 2. Testing the microphone. Testing, testing. Microphone testing. Testing the microphone. Testing, testing. Testing the microphone. Testing. Seeing how loud the microphone is. There we go.
Testing, testing. Testing, testing. 1, 2, 3. Testing. Microphone testing. Test, test. Testing, testing.
1, 2, 1, 2. Testing the microphone. Testing, testing. Microphone testing. Testing the microphone. Testing, testing.
Good afternoon, and thank you for joining today. We have a very different January than expected, and for that I'm grateful. Today I'll be going over our trend lines, community level, and some updated metrics we have around the effectiveness of the bivalent booster. I know that XBB.1.5 is also on people's minds, so I'll be showing the most updated information relevant to LA County. I'll take the next slide. As I do every week, I'd like to start with our updated trend lines to give an overview of where we are in LA County with COVID-19. Numbers of cases, hospital admissions, and deaths can provide a broad overview of COVID-19 levels and information about where we need to focus efforts. This slide shows trend lines from April 1st of 2022 through today. The green trend line shows the 7-day average of the number of cases reported daily, and it's measured using the vertical axis on the left. This week, the average number of cases reported per day is 1,100, compared to an average of 1,900 cases reported per day last week. Since the beginning of January, we have seen a generally consistent downward trend in case numbers. As a reminder, we do recognize that many cases go unreported, especially due to at-home testing, so our reported cases today are very likely a significant undercount. The orange trend line shows the 7-day average of hospital admissions. This past week, there was an average of 136 admissions per day. This number also continues to decline, and it's significantly lower than the peak we saw in late December and early January, when the average hospital admissions per day surpassed 210. For the week that ended January 2nd, which is the most recent week we have data available for, 43% of COVID-positive hospitalizations were determined to have COVID-associated illness, meaning they were admitted for COVID rather than with COVID. While the impact of COVID on the healthcare system remains manageable and stable, our hospital admission numbers are still about double what was seen in October and early November, and you can clearly see that on the slide. The blue line on this slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. We're currently reporting an average of 20 deaths per day, which remains relatively high compared with the deaths before Thanksgiving, when we were averaging about 8 reported daily deaths. Deaths, as we noted last week, remain significantly higher among our older residents and people who are living in higher poverty areas. This week in LA County, we surpassed a somber milestone as we marked 35,000 deaths due to COVID-19. It is critical to help protect people who are at higher risk for severe illness and death. And I'd like to extend my heartfelt condolences to those who have lost a loved one to COVID, and I offer wishes for healing and peace. Next slide. In addition to case rates, we use wastewater data to better understand the levels of COVID-19 circulating in LA County. The graph on this slide displays our wastewater viral concentrations of SARS-CoV-2 from May 29th of 2022 all the way through January 7th of 2023. This metric tells us about COVID-19 circulation that's likely not to be reflected in our reported case counts. The blue line is a weighted average for viral concentrations across 4 wastewater treatment plants, weighted by the population served by each plant. The drop that we've been seeing in our SARS-CoV-2 wastewater concentrations appears to have been plateauing these last couple of weeks at just under 70% of the summer surge peak concentration, maintaining levels that are still in the high concern category set out in the LA County early alert metrics. While wastewater concentration levels are not low, simultaneously we're not seeing the post-holiday spike that was expected by the end of the first week in January. It could be tempting to interpret this as COVID is no longer being a concern. However, the more reasonable explanation is that the new tools and people's behaviors have made a difference in how COVID spreads, and that even small precautions are making a difference as well. Next slide. As part of continually assessing the impact on our healthcare system from COVID-19, we regularly look at how our emergency departments are being impacted. This slide shows the 7-day average of the percent of emergency department encounters that are classified as COVID-related, and we're looking at dates from October 1st of 2022 through January 15th of 2023. Currently, this metric is at about 5%, reflecting a steady decline since early January in folks coming to the emergency room for COVID-related illness. We haven't, but you can see we haven't reached a level yet that would be classified as low concern. In addition to taking steps to reduce transmission, such as masking, the number of emergency department encounters associated with COVID-19 can be reduced with an uptake of the bivalent booster and use of therapeutics, especially for those with underlying health conditions. Next slide. Using the CDC's community levels framework, which looks at case rates and 2 different hospitalization metrics, this week, LA County moves to the low community level with a reported case rate of 75 new cases per 100,000 people. For the first hospitalization metric, the number of new COVID-19 admissions per 100,000 people, LA County is currently at 9.5. This is down from a rate of 11.9, which we reported last week. And it's just below the threshold of 10 that would have kept us in the medium community level. For the second hospital metric, the percentage of staffed inpatient beds occupied by COVID-19 patients, LA County is currently at the 5.8%. That's also down from 6.7% that we reported last week. While our case rate clearly represents a serious undercount, the fact that we are also seeing declining hospitalization-related numbers means that many infected people are recovering from their illness without requiring hospital care. Next slide. With a change in our community level, I also want to share updated indoor masking recommendations in accordance with our LA County COVID response plan. In the low community level, masking for many people at many indoor sites is an individual preference unless one of the following situations apply. Per state health officer order, masking is still always required in healthcare and congregate care settings. Indoor masking is also required for anyone who has been exposed to COVID-19 for 10 days after their last exposure to a confirmed case. A high-quality, well-fitting respirator mask, such as an N95, KN95, or KF94, provides the best protection. In addition, everyone should mask where it is required by the site, including in places of business, schools, and workplaces. Places all have the authority to set their own requirements, and work sites and schools should continue doing everything they can to prevent transmission of COVID-19 based on their communities and their individual needs. Masking remains strongly recommended in all indoor spaces for people who are at elevated risk for severe illness or death from COVID-19. This includes people who are older, people with underlying health conditions, and those who may be exposed to large numbers of people in their job or who work in very crowded places. If you contact COVID-19, you need to isolate for a minimum of 5 days after testing positive. If you have a negative test on days 6 through 10, you can go out, and at that time, masking is strongly recommended, through day 10. In workplace settings, I just want to remind everyone, masking is required for the full 10 days after testing positive, and this is per Cal OSHA. Masking also continues to be strongly recommended on public transit. While in correctional and detention facilities, as well as homeless and emergency shelter sites, masking is now an individual preference. High-risk people in these settings should continue to mask, and those that serve them should consider masking indoors as well. Next slide. While we're reassured by our current metrics, throughout the pandemic, changes in dominant variants have driven periods of high transmission, increasing risk in the community. In order to better understand what strains are circulating, each week a portion of positive COVID specimens is sequenced to determine the lineage that caused the infection. And this can help us better prepare for possible changes in transmission patterns. In LA County, as of December 31st, BQ.1 and BQ.1.1, represented by that light pink and those purple bars at the top of the graph, continue to be our dominant strains. Cumulatively, they account for about 68% of sequenced specimens. At the top of the graph, you can see that we're tracking XBB, that's the yellow bar, and XBB.1.5, that's the orange bar. In the most recent week, XBB accounted for 5.5% of specimens, and XBB.1.5 accounted for 4.8% of specimens. The CDC calculates predictions of the estimated proportion of each COVID strain circulating now, since, as you can tell, there's a 2 to 3 week lag in lab data due to the time it takes to sequence specimens. For Region 9, which includes California, the CDC predicts that XBB now accounts for 6.5% of specimens, and XBB.1.5 accounts for 15.8%, while BQ.1 and BQ.1.1 cumulatively account for just over 66%. In LA County, variants are shifting slowly, so we don't expect them to drive a large increase in transmission in the very near future. Based on this, I'm hopeful that we'll continue to remain in the low community level for at least several weeks. Next slide. I do continue to hear questions about XBB.1.5 and if this strain could drive a potential surge. If it could be the same as what we saw when Omicron emerged last winter and cases, hospitalizations, and deaths dramatically increased. While nothing can be said with certainty, currently we're seeing evidence that our tools to fight COVID-19, including masks, the bivalent booster, and therapeutics, are working. This table shows XBB.1.5 estimated percentages based on the CDC estimates for the Health and Human Services regions and related hospital metrics, the same ones that are used to determine the CDC community level. Each column shows information for a county with a major city, including Manhattan, Boston, Atlanta, LA, Chicago, and Seattle. New York County, Manhattan, on the left, has the highest estimated proportion of XBB.1.5 at about 83%. And Seattle King County, shown on the far right, has the lowest with just over 8%. When looking at this data, it's apparent that to date, XBB.1.5 is not driving huge increases in COVID-19 hospitalizations. For example, in Atlanta and Fulton County, they're reporting a daily average of nearly 9 new COVID-19 admissions per 100,000 people. And that's less than the 11 that are reported for Chicago Cook County. However, the estimated proportion of XBB.1.5 for the Atlanta area is more than double that for Chicago. For LA County, the estimated proportion of XBB.1.5 is slightly higher than Chicago Cook County, yet our hospital admissions are lower. There are a lot of underlying variables that are affecting hospitalization rates in different regions, including local policies, vaccination rates, and even behaviors that change according to the weather, such as being inside more. And while we need to continue to track the impact of increased circulation of XBB and XBB.1.5 on illness severity, the current information suggests that this strain of Omicron is not having a major impact on hospitalization rates as of this time. This provides some reassurance that effective use of the tools we have to work with that mitigate the impact of this new strain of COVID-19 are in fact effective. Next slide. Lessening the impact of COVID is especially important for those with underlying health conditions and comorbidities, factors that can amplify the seriousness of a COVID-19 infection and can result in increased hospitalizations. On this slide, we look at the comorbidity status of a subset of LA County COVID-19 hospitalizations. To collect this data, a random set of 120 medical records per week are selected for chart review from LA County residents that are hospitalized for COVID-19. Patients whose COVID-19 hospitalization was incidental to the primary reason for hospitalization, such as they're in the hospital because of trauma or a surgery, are excluded from this analysis. On this chart, the yellow bars at the top represent people hospitalized with COVID-19 who had 3 or more comorbidities. Those are other illnesses. The purple is people with 2 comorbidities, the blue is 1, and the green portion represents patients with no comorbidities. Comorbidities include things like chronic lung disease, asthma, stroke, kidney disease, liver disease, dementia, a history of cancer or immunosuppression, among other things. Type 2 diabetes, hypertension, and hyperlipidemia, which is an abnormal elevation of lipids such as cholesterol, were the most frequently reported comorbid conditions. Of patients included in this analysis, 80% were 46 years of age or older, and 57% were overweight or obese. Between October and November of 2022, when we collected the data for this sample, 44% of the hospitalizations analyzed were among individuals that had 3 or more comorbidities. 28% of the people had 2 comorbidities, and less than 10% of people had no underlying health conditions. Often when assessing one's own risk, we can hear recommendations that are intended for people who are at increased risk, and we assume that because we feel healthy, that advice is not for us. However, this data emphasizes the risk from ignoring even seemingly common underlying health conditions. Next slide. One tool for reducing hospitalizations are vaccines and boosters that have been shown in multiple studies to confer protection from severe illness associated with COVID. The bivalent booster, widely available in LA County since September, is formulated to provide increased protection against the Omicron variant and its sublineages. On this slide, I'm able to share the hospitalization and death rates over the past 30 days for LA County residents who are unvaccinated compared to residents who are vaccinated without the updated bivalent booster and residents who are vaccinated with the updated booster. And while this data has some limitations, it can help us understand differences in hospitalization and death rates associated with vaccine coverage. The yellow graph is hospitalization rates per 100,000 people, and the blue graph is death rates per 100,000 people. Hospitalization rates as of the 30-day period that ended January 3rd were over 3 times higher for people who were unvaccinated compared to people who were vaccinated without the updated booster. For those vaccinated without the updated booster, hospitalizations were almost 2.5 times higher than for people who had additionally received the updated booster. Overall, people who were unvaccinated were nearly 7 times more likely to be hospitalized compared to people who had the bivalent booster. It's sobering to look at these same comparisons for death rates for the 30-day period that ended December 27th. People who were unvaccinated had death rates that were more than 4 times greater than people who were vaccinated without the updated bivalent booster. And for people who were vaccinated without the updated booster, the rate of death was more than 2 times higher than people who had received the updated bivalent booster. Unvaccinated individuals were almost 9 times more likely to die than those who had received the bivalent booster. While vaccines are not a guarantee against severe illness and death, recently there has been mounting research and clinical evidence showing that they provide significant protection. And now we can see this reflected in our own numbers in LA County. Often I hear that people tell me that they don't realize that they need the updated booster. The updated bivalent booster is now available for people as young as 6 months old. People also mistakenly think that they don't need updated protection because they have previously had a COVID-19 infection. But immunity from an infection wanes over time. If it's been more than 3 months since you had a COVID-19 infection, it does make sense and it is time for the updated booster. And this data helps us understand how it does provide this increased protection. Next slide. Moving into low community level is a welcomed beginning to 2023. It tells us a lot about what's happening in LA County. Cases are more manageable and hospitalizations are down. However, there are many people for whom COVID remains very real. And in order for us to stay in community, in this low community level, we all need to continue to take actions that provide protection that reduces transmission, and particularly to remember to protect people who are most vulnerable. A bivalent booster can provide protection for yourself, and it reduces the chances of serious illness from COVID-19. This is especially important for those in our community who are older or have underlying conditions. Bivalent booster rates in LA County are at just about 22%. And if we can increase this number, we can increase our level of community protection and continue to reduce strain on the healthcare system. We are particularly concerned that about 60% of residents 65 and older who are eligible for the new bivalent booster have not yet received this additional protection. You can visit ph.lacounty.gov/how-to-get-vaccinated to learn more about the vaccine, to find locations where the vaccine is available, and to get information about transportation to a vaccine site, or to get information about how to schedule a home visit if you're homebound. Also, masks do continue to provide protection, especially in indoor, crowded, or poorly ventilated spaces. They're a fantastic tool against the spread of COVID-19, as well as other respiratory illnesses, including flu and RSV, that can be circulating. They're an added level of precaution, and I do urge people who regularly interact with family members or loved ones who are more vulnerable to consider wearing a mask to minimize the chance of spreading infection. Using at-home tests are also a simple way to make sure you're not passing anything along unintentionally. So test before gatherings if you've been exposed or if you have any symptoms. It's possible that you have an idea of what COVID symptoms are in your head from back in 2020, when telltale symptoms were the loss of taste and troubled breathing. While these are still possible symptoms, as the virus has changed, common symptoms now include sneezing, a runny nose, a sore throat, or a headache, and this can be different for each person. Don't risk an incorrect guess about whether you have COVID or something else. You can go to ph.lacounty.gov/COVID tests, get more information, find a link to order those free at-home tests from the federal program. As a reminder, insurance plans are required to reimburse for up to 8 home tests a month per insured member. And last, but equally important, if you do test positive or you have symptoms, talk to a provider about therapeutics that are available by prescription and can be taken at home. Medication does need to start within 5 days of symptom onset. If you don't have a provider, you have questions, please use our telehealth care service 7 days a week, 8 a.m. to 8:30 p.m., and you can access support by calling 833-540-0473. Folks on this line will allow you can speak to a provider, you can ask questions, you can get advice, and you can also receive a prescription for therapeutics if they're a good fit. If you're given a prescription, the medications will be shipped to you overnight at no charge. In closing, my biggest fear is that within this optimism, people who are most vulnerable, those who have been seriously impacted the most by the pandemic, will be left to fend for themselves. Moving into low community level is significant and it reflects reduced risk, but it doesn't mean no risk. And certainly for those who are most vulnerable, risk remains significant. Low community level is not a promise, and it doesn't signal the end of the pandemic. We'll have to wait to see how metrics continue to change over the coming weeks. It does show that we know a lot more about COVID-19, including what works and how to effectively use the tools we have. My hope is that people will continue to be smart about navigating life with this virus, and that we're truly entering a new phase. I welcome any questions now.
Marla Tejas, Fox 11, I'll let you have the first questions.
Thank you, Dr. Ferrer. Last week, we talked about COVID hospitalizations and how those are counted with and for. Then there was a conversation that was sparked after an op-ed was written by a well-known public health official talking just about that and even overcounting deaths. We marked the grim milestone of more than 35,000. So what's your take on that? Are we overcounting COVID deaths? And who is the decision maker when it comes to deciding on if a patient did die because of COVID?
Yeah, great questions. One thing I do know is that CDC is looking at making some revisions to how deaths are counted, and the state will review that. And again, as I noted before, if the state adopts a change in the definitions, will of course align with those changes. And I think it is because questions have been raised, particularly around associating those positive test results with a notation that a person has died of COVID without doing a more thorough review of the record to make sure that, in fact, those two were linked. So I think that's what they've been looking at the most. I know when we looked at our data, we're estimating that maybe 15 20% of the deaths that we're counting right now, so it's very hard to go back in time, so I'm not going to. But the deaths that we're counting right now those designations might change if there is a reclassification. But we won't know until we see the exact language. What I can tell you is that, we will align fully with any changes that are made by the state.
Okay, so understanding everything you just said.
Yeah.
35,000 plus in this county. So you're saying that 15 to 20% could be an overcount.
Of recent deaths. You
Okay.
can't, it's very hard to go back in time
Okay.
and apply this algorithm back in time because we didn't have the same tools we have now. So I think of the recent deaths that we're counting, we might see a shift. Maybe it's 10 to 20%. It's going to be hard to tell until we see the new definition.
Okay, and is it a primary care physician who makes that call in the end?
It's generally, the vast majority of the patients who die in the hospital, so it's generally a healthcare provider at the hospital who makes a designation. Sometimes it's the coroner's office.
Okay.
It's not an individual person, a lay person, I can promise you that. It's generally a person who's been caring with the patient at the point of their death.
Okay, and then a clarification, if I could. In the beginning of the presentation, you talked about for and with COVID, I think
Yeah.
so, hospitalizations anyway. And you said 43%, if I'm not mistaken,
Yep,
are
that's right.
there with COVID?
Yes. When they are admitted, they're admitted with COVID.
Okay. And then also the discrepancy sort of, I know you see the press conferences that are done from LA USC Medical Center and the doctors there, and they really paint a picture that is so different than what we get here each week. Can you explain that?
Well, I actually haven't seen their press conferences, but I do know every hospital is different, and they're one of about 80 hospitals in LA County. They serve, I think, about 3% of the hospitalized patients in LA County.
Are they not the biggest?
I wouldn't know how to classify on the biggest, but I can tell you that I believe the percent of patients that they serve is about 3%. And I do know there's just lots of other hospitals as well. So all we're really reporting on at these press briefings is sort of the collective data that we get from all of the hospitals.
Dr. Frere, I have three questions from Ron Lynn at the LA Times. Question one, you shared with us a lot of promising news today. Are we in the clear for a while, or is it more complicated than that?
Yeah, thanks so much, Ron. I never say we're in the clear because there's still people for whom COVID is going to remain a really big concern, and they're going to continue to need to do everything they can to avoid getting infected. We still have a lot of virus in our communities, but we are definitely in a promising place. And given what we've seen so far about the new circulating variant of concern, which is really XBB and XBB.1.5, and the slower increase here in LA County, I can say with a lot of confidence that the next several weeks, we don't expect seeing any big surges. Now, again, there could be a new variant or a new strain on the horizon percolating somewhere, because there still is a lot of transmission, not just here, but around the world, that we're going to have to worry about. And it's going to change conditions for us and for other counties in the future. But for the next several weeks, I think we're very likely to stay in this low community level, certainly wouldn't move back to the high community level. And I think that is a reflection of tools that work and people that are using those tools.
Right. His second question, the chief of the WHO has expressed optimism that the pandemic global emergency could end in sometime this year. What kind of thresholds would you imagine that we would need to reach for ending that health emergency?
It's going to be very hard for me to comment on sort of the worldwide emergency declaration. I can't say that locally. What we would want to see is a lower mortality rate associated with COVID. And that would really mean at this point in time that our vaccines are working well and our therapeutics are working well. And I think, as we've noted before, if you've got really good vaccines and you have really good therapeutics, your mortality rate should significantly drop.
Great. Florida's governor has called on lawmakers to make permanent its state's ban on masks and COVID vaccine mandates at schools and government, and a ban on COVID-19 vaccine requirements for employment. What do you think of the idea of prohibiting schools from requiring masks or businesses from requiring COVID vaccinations?
I think it's very difficult to have so many different opinions about what makes sense for everyone. And it's particularly, I think, difficult for those that are running businesses and those that are running, in this case, schools, to sort through the different opinions. I will say, my heart goes out to the women who were featured in an article in the LA Times, the Latino women who organized themselves, pleading for more people to wear masks at schools because they're frightened, extraordinarily frightened, on the exposures for their children. Many of their children are medically fragile or have underlying health conditions, and or they live with family members who are medically fragile and have underlying health conditions. And many of them have experienced the worst of this pandemic by losing people in their families and continuing to suffer the consequences of a lot of exposures and a lot of infections. So I appreciate the schools that are looking at the community conditions, that are listening to the people in their community and making thoughtful decisions that really, take into account the differing needs of the population being served. I remember, like way back when my children were young, when people started discovering a lot more about allergies, and you would get a note saying, there's a child in the class that has a peanut allergy. Not a single parent would have thought, the request was, please don't send anything with peanuts into school. And, the entire class would adhere to that. Yes, it was only one child, but everybody understood that they had an opportunity to create a safer space for that one child. I hope we continue to sort of operate, in these different times with a similar philosophy, that there are children who need additional help from all of us. And, we should do our very best.
Okay, thank you.
I have one. Sorry. I was just trying to put it together in my head.
Stating your name and address.
JR with KTLA 5. Dr. Ferrer, going back to the variant surveillance slide, you were talking about, sorry, trying to pull my notes here, the
XBB.
The XBB and the XBB 1.5. Do you have any data to show if there's an effect on people with comorbidities on the viral load with that particular strain? I mean, should we be concerned about that?
I think for people with comorbidities, the message is pretty clear. You should be concerned and do your very best to avoid becoming infected with COVID. And again, with every new strain, it does take a while for the researchers and the scientists to do exactly the reasonable request you're making, understand, is there a relationship in viral load? Is there a relationship that puts people at particular risk if they have certain underlying health conditions? Are there advantages? I mean, we saw some new data that suggests that even if you have underlying health conditions, if you exercise often, you may do better. So, I am impressed with the rapidity at which our researchers and scientists try to gather the data for us, because every new strain means a new set of studies and a new look back at the data that we have.
Thank you.
Yesterday, I interviewed an LAFD firefighter who has been on unpaid leave for not getting the vaccine because, of course, LAFD still has a vaccine mandate in place. He's going through a process where his fate will be determined by the Board of Rights. He's not alone. I'd like to get your thoughts on that. Given that where we are in the pandemic, the Pentagon dropped its vaccine mandate for troops. What are your thoughts?
I think, again, I don't want to be second guessing other departments' decisions that other cities and counties are going to make. I understand that there were, as there are with healthcare workers, there are certain groups of employees or workers that are required to pass additional tests or be vaccinated against particular diseases. I mean, we're healthcare workers, so we know this well because we interact with a very vulnerable population. And so I appreciate that there's a lot of discourse. I'm not sure I would compare, those first responders with the general public in terms of the vaccine mandates.
Meaning, do you think that his job should be reinstated?
No, meaning that I think that there needs to be thoughtful consideration of what protections are going to be required of those that interact with very vulnerable populations. Many of our firefighters, as you know, are the first responders in medical emergencies.
And one more layer to that story is that there are almost 350 within LAFD alone that have filed for an exemption.
Yep.
And because they've filed that paperwork, they are still allowed to work. So there are that many out there unvaccinated working. But if you didn't file for an exemption, you're on unpaid leave.
Yeah. I think, again, out of respect for the fact that there may be medical exemptions, and in this case also religious exemptions, an exemption policy has been set up, really that tries to make sure that the vast majority of people are going to have the additional protections that, really confer advantages to the people they're serving. But I am in favor of an exemption policy, and I urge people to go ahead and use an exemption policy.
And I don't think I was clear in that those exemptions are pending. So they haven't been ruled on one way or the other.
But they're still working and they're taking additional precautions. I know for us, we have some people still going through the process, and they've been reassigned to duties that minimize their interactions with the general public.
You opened the briefing, and I'll be done after this, saying that, we're in a much different January than you expected, and how quickly we went from, you talking about a potential mask mandate to here we are now in low, which is wonderful. Great way to start the new year. How do you see your role evolving if we continue to see these numbers decline? I mean, do you foresee that you're going to be holding these briefings?
Well, we certainly won't need to hold a lot of briefings. I mean, already, we've canceled a few briefings because there just wasn't a lot of additional information. We always want to be responsive, and we always want both the media and the public to feel like we're sharing all of our information. And, for much of the pandemic, the information has changed really rapidly. As information doesn't change as rapidly and as conditions stabilize, I think there's less need for a media briefing, although I would anticipate you should know that, we will always be updating our dashboards on our website and always be sending at least a weekly press release out to the press, and always here to respond to questions. But yes, I mean, if we are entering a new phase, we'll be looking at all of our response activities to sort of right-size the work that we're doing to that new phase.
Do you have a response to me being the only one here in the room today in terms of a reporter? Meaning, how does that make you feel when you spend the time to do this?
Well, I mean, we're responding. I mean, we still have a lot more people that attend virtually. We're responding at this point to the request that we do hold these in person, and we're happy to do that. And we'll continue to do that even if there's only one person that, feels like they're advantaged by this. It's really, for us, it's not additional work to hold these in person. I think the question is how often do we need to hold briefings? Not whether we'd hold them in person or not. I think we're all comfortable holding them in person.
I've worn out my welcome, but I just had to follow up on the LAFD story. Isn't that your order?
No, it's not our order. We do not, no, we have no orders that apply to the workforce for the city of LA.
I got one question, but it's not about COVID.
Okay, well, I'll try.
Okay. I used to have slides up there that showed your RSV infections.
Yeah, I'm happy to answer.
Okay, so where are we at with RSV
Yep.
in LA County, and your reaction to Moderna's latest research on the RSV vaccine? Thank you.
Both influenza and RSV are on a pretty significant decline. With RSV, we're confident that this decline will probably last, and we're probably seeing sort of the tail end of a highly infectious period for RSV. That doesn't mean that there's not RSV circulating. There still is, but we don't see anywhere near the steep numbers of cases and positive test specimens that we saw earlier. The same holds true for influenza. We've also seen a pretty steep decline. I do want to say with influenza, we've had a few seasons where we have had like two phases during the season. We've had one phase that starts, around November, and another phase that sometimes kicks off sort of at the middle, end of January. So we're still going to need to wait to see whether we have a second phase of influenza. But for both those, there's a decline. I appreciate everything that all of the sort of the drug companies, the researchers, and the scientists are doing to address the fact that we've got respiratory illnesses and other diseases that cause significant hardship, devastation, serious illness, death, and that they do their very best to come up with vaccines that provide a level of protection we all benefit from. Thank you. We're good. Thanks, everyone. Thank you. Thanks, team. Great job. Thank you.
Oh, you're very welcome.